Good afternoon. This is Drew Saelens from Zero, the End of Prostate Cancer, and I'm joined by Ana Fadich, Vice President at Men's Health Network. And on the phone, we have Dr. David Penson, Chair at the Department of Urologic Surgery at the Vanderbilt Ingram Cancer Center on behalf of the American Urological Association. Zero, Men's Health Network, and the American Urological Association have worked closely for many years to educate men and policymakers about the importance of prostate cancer screening. Today, the U.S. Preventive Services Task Force published updated draft recommendations for the prostate-specific antigen test. The new draft guidelines upgraded the task force rating for the PSA test from a D rating to a C rating for men between ages 55 and 69. The AUA, MHN, and Zero are encouraged by the USPSTF's draft recommendations. The prostate cancer community has worked for a long time to educate men on the importance of understanding their PSA numbers and shared decision-making with their physicians. And we view today's draft recommendation as an incremental victory for men's health. Ana, we were talking as you came in. You and I have actually worked on the PSA recommendations since probably 2010 or so. This is a big deal. So what does it actually mean for men and their families?
Well, thanks for having us here today, Drew. So the C rating is a huge step forward for men's health. It basically means that any of these hospitals and physicians who are currently following USPSTF guidelines are now able to screen their patients. They're able to conduct PSA testing, and they can talk to their patients about it. As you know, back in 2012, the USPSTF had recommended against prostate cancer screening. They gave it a grade D, meaning don't do it. There's not enough evidence for positive or negative results. So more harm than good. So today, the recommendations came out, and so that's great for us because the C recommendation means that patients are now going to be able to talk to their doctors. As you said, men 55 to 69 are going to be able to have that conversation with their doctor about what personalized medicine can do for them. So what is the right thing to do? Is it radiation? Is it surgery? Is it chemotherapy? They can have that conversation now. With working with the different organizations across the country, everybody has the same message. Make sure that men get screened. The task force did recommend that men over the age of 70, they still have a D rating not to get screened. Men's Health Network recommends that all men still should go and get their screenings done. When it comes to high-risk populations, African Americans, those Vietnam veterans who are exposed to Agent Orange, and men with family history, we recommend that they go even earlier than 55. We recommend that men get a baseline PSA at age 40, and that way they can follow their trend across their lifespan.
Sure, that's great. So I like that D was don't get it, and C is now see your doctor.
Yes.
And definitely go get that prostate cancer screening. So thanks, Ana. As I mentioned, we're also joined by Dr. David Penson on the phone. Dr. Penson served on the AUA's Public Policy Council from 2008 to 2016, first as vice chair and then as chair. Dr. Penson has been intimately involved in working on the reform of the USPSTF and was involved in the recommendation process with respect to the PSA screening, particularly ever since the D rating came out in 2012. So, Dr. Penson, thanks so much for joining us on the phone. Could you give us a little background on the evidence that led the USPSTF to change their rating from a D to a C?
Sure, I'm happy to, and thank you guys for having me. It's really a pleasure to represent the American Urological Association, which is the premier specialty society for urology, and we're really pleased with this change, and we really commend the USPSTF for doing this. This is a really truly a good thing for men in this country. Because now they can go and discuss screening with their physicians, and as Ana said, it's a C now, so see your doctor as opposed to D, don't do it. Now, I want to start by just making it clear what my role was, because there's been some confusion, at least in the physician community among the urologists, as to what we did. I was not on the task force panel. I'm not privy to their internal discussions, but I was asked to review the evidence reports they looked at to make their decision and to submit comments and ask the authors to make changes to the reports. And they did make some changes, having seen the reports as they were presented. And I think that shows just how responsive the task force was to the input of physicians, patient advocacy groups, and other stakeholders in this iteration of their recommendation, and I think that's really positive. Now let's talk about the evidence like you asked me to start with, Drew. And basically there are two big studies out there that the USPSTF has used to make their decision. In fact, these are the same studies they used in 2012. The first study was an American study called the PLCO study, or the PRECO study. That stands for prostate, lung, colon, and ovarian screening. And it's a big study of about 70,000 to 80,000 American men who were followed in the 90s who were randomized to either get a PSA test or not. And that study showed no benefit for prostate cancer screening. But that study has been criticized because the control arm, the quote-unquote no screening arm, there was a lot of screening that went on in there. Some people say there was more screening in the control arm than there was in the quote-unquote screening arm. And there's debate about that, but no one's arguing that the patients who were in the no screening arm got some screening. And so to some degree, the task force looked at those data this time around and acknowledged that perhaps that's not as strong a study as we would like, and it's not as helpful when we're looking at the question of screening versus no screening. The other study is a European study, which is called the ERSPC study, the European Randomized Study of Prostate Cancer Screening. And that's also a very large study of about 180,000 men from 8 different countries. And again, the men were randomized to screening versus no screening. And that study showed an advantage. Now, it wasn't a huge advantage to screening, but there was some advantage. Basically, when they looked at prostate cancer survival, what they said for every 1,000 men screened, about 1 to 2 men had their lives saved by screening. So not a huge impact, but definitely some impact. And more importantly, this time around, the task force looked and said, let's not just look at survival, let's look at other outcomes that make a difference to men with prostate cancer. And one thing that any man with prostate cancer is going to be worried about is having the cancer spread, what we call metastatic disease. And they looked and they said, for every 1,000 men who are screened, roughly 3 men will avoid metastatic prostate cancer, which is a terrible thing to have. And the task force looked at that and said, well, you know what? The benefit here is actually a little higher than perhaps we gave it credit for last time. The other thing the task force mentioned, and I think this is very important, because if you go back to that D rating that they gave in 2012, what they said was, there is some benefit, but it's small, and there are a lot of harms. And they felt in 2012 that the harms outweighed the benefits. Now what they're saying is, there are pros and cons, and each man's going to make his individual decision. One of the things they also took into account was they said, look, if we look at how things have changed in prostate cancer care in the United States in the last 5 years, we're seeing a lot more active surveillance in men with low-risk disease. These are the guys who have very slow-growing tumors, and we can pick them out as docs because we look at their cells under the microscope, and they're low-grade. They look less aggressive. And so the task force looked and said, maybe there's more benefit than we saw the first time. And there's certainly less harm because there's less overtreatment. Those men with low-risk disease probably don't need to have any treatment. They probably can be observed safely. And by avoiding this extra treatment, you avoid the harms of treatment, the impotence, the incontinence, the bowel dysfunction that we all know goes with surgery and radiation. So when the task force looked at that, they took those two new pieces of evidence, one about the new outcome of metastatic-free survival, and the other one, the decline in harms. They put 2 and 2 together and said, you know what? It's not so clear anymore that the harms outweigh the benefits, and each man should discuss the pros and cons with his doctor and make a personal choice if he wants to get screened.
Okay, so large trials over many years have real-world impact results that have changed this screening recommendation. And now, just as you said, men are supposed to have a personalized, individualized conversation with their doctor. How can men and their families advocate with their doctor, with their primary care physician, or with their urologist to understand the benefits versus the harms?
So I think it's really important that patients men be aware of this. You know, if you're certainly a man of normal risk, you know, if you're a white man with no family history, you should be talking to your doc about this at age 50. And as was mentioned before, if you're higher risk, you know, you're African American, you have a strong family history, you're exposed to Agent Orange, you might even want to bring it up with your doctor earlier, say around age 40. And if the doctor doesn't, you know, come and have, you know, doesn't feel comfortable having the discussion, then one thing you can do if you're with your primary care provider is ask for a referral to a urologist. Most urologists are very well versed in the pros and cons of prostate cancer screening and can really talk to a man about what's going to happen if you get that PSA test. What's going to happen if it's elevated? What does that mean? What are we going to do next? What if, God forbid, you have cancer? What are we going to do? So that way a man and his family can sit down together and think, do I really want to have this blood test? Is it really worth it to me? Do the benefits outweigh the harms in my case? The other thing that's worth mentioning is that there are a lot of resources available online and in print that can help men think about this. You know, I'm sure that many of your organizations like Men's Health and Zero have materials. I know the AUA has materials to help men. There are materials that have been developed by the CDC, by the Agency for Healthcare Research and Quality. So men can go online. You know, the Foundation for Medical Decision Making has a nice tool about prostate cancer screening and can read about it even before they go in to see their doctor. That way they can come in and be informed consumers when they're talking to their doc about whether or not they want to get that blood test.
Great. Well, that's perfect advice for men. You mentioned high-risk groups, and Ana, you mentioned high-risk groups as well. So what did the actual recommendation this time around say to these high-risk groups like African Americans and men with a family history of prostate cancer? What did it tell those men to do?
Yeah, and so that's tough, and the reason it's tough is because most of the two big trials don't have a lot of African American men in those trials, and there are also not a lot of men in those trials who have strong family histories of prostate cancer. So the task force itself, because they didn't really have good evidence, ended up saying there was no one correct answer about screening for men who are at increased risk. So they encouraged African American men, and this is a direct quote, to talk to their clinician about their increased risk of developing and dying of prostate cancer, as well as the potential benefits and harms of screening. Men with family history of prostate cancer should also talk to their clinician about the potential benefits and harm of screening. And this is particularly important for men whose father or brother have been previously diagnosed. And I think that that's really good advice on the part of the task force, because unfortunately in this setting, we just don't know the right way to screen for these high-risk men. I would argue, and this is my opinion, that look, if you are at higher risk for getting the disease, you're likely going to garner a higher benefit from screening, and so that risk-benefit ratio in these high-risk men is probably one that would, if I was a high-risk patient, would lead me to want to be screened. But each man's going to have to make his own decision, and unfortunately, we just don't have as much good clinical trial evidence to say what is the right thing to do for these guys who are at increased risk.
But Drew, that's where we come into play. You know, groups like Men's Health Network and Zero, you know, we're out there on the ground, we're online, we have a lot of that educational material talking to these men specifically to say, hey, if you're African American or if you have a family history, go get checked.
Yeah, I think it's very important to point out that the USPSTF did the best with the data it has, but as you both have pointed out, the data just wasn't there for them to make a recommendation, but it doesn't mean that that high-risk group isn't out there and that they could benefit more from screening.
And we need those high-risk groups to participate in the clinical trials. So if you know there's a clinical trial out there, or contact one of our groups, we can help direct you to clinical trials.
Yeah, that's a great point. So, Dr. Penson, thank you so much for joining us, and thank you for your work as both a policy influencer and a medical practitioner. We really appreciate it.
Thank you so much. Thanks for having me.
So, as Ana just alluded to, the USPSTF identified several research gaps, including African American men and men with a family history, as well as developing longer-term studies that validate the diagnostic techniques as well as the adjunctive diagnostics that go along with the PSA test. So, how are we going to fill those research gaps? Well, I think the AUA, MHN, and certainly Zero would call upon industry, patients, as you just mentioned, enrolling in the trials, and researchers to concentrate on those research gaps that were mentioned in this draft recommendation and find ways to fill them so that in 5 years, when the task force goes to review the recommendation again for PSA, there's enough evidence to draw a conclusive recommendation for some of these high-risk groups and maybe even other men, like older men or younger men. But we need the data to be there, otherwise the recommendation doesn't come with it.
Right.
So I wanted to let you guys know that the recommendation is open for public comment until May 8th at 8 p.m. And you can visit www.screeningforprostatecancer.org. That's www.screeningforprostatecancer.org to make your comments. On behalf of Zero, Men's Health Network, and the American Urological Association, I want to thank you for watching and your continued support of the prostate cancer community.
Get it checked.